My name is Dr. Zafir Islam.
And my name is Dr. Laura Klar. We're both doctors at Imperial College Healthcare Trust.
The name of our project is the impact of the design of an electronic sepsis alert on the number of patients with confirmed sepsis at a London multi-site hospital network.
The Imperial College Healthcare NHS Trust is a multi-hospital organisation with 250,000 emergency department attendances, 200,000 inpatient contacts and over 100,000 inpatient operations a year. Sepsis care at the Trust is supported by an electronic screening protocol. It screens the observations including respiratory rate, blood pressure and heart rate, and laboratory results including blood glucose, white cell count, lactate, bilirubin and creatinine. The sepsis alert is generated when a patient demonstrates signs of sepsis. A physician is notified that a prompt review is needed when they open the patient's record. The sepsis alert form asks the physician the following question. Having reviewed the patient, does this patient have sepsis or severe sepsis? The options were originally either known sepsis or no. Important to note, since its introduction, we have demonstrated the effectiveness of the sepsis alert by reducing the risk of mortality by 24%. However, we found that the response rate for the sepsis alert form was poor, approximately 62 to 68%. This quality improvement project aimed to increase engagement with the sepsis alert form by finding the reasons behind this and thus making changes to improve response rates.
Methods of the project. The Sepsis Big Room is a weekly multidisciplinary meeting where staff share patient stories and discuss improvements to sepsis care, as well as reviewing real-time data from our electronic system. All patients who triggered a sepsis alert and had general acute admissions across the trust were included. The meetings revealed that clinicians felt the options to the sepsis alert form did not represent the diagnostic uncertainty/difficulty of sepsis. Detailed discussions revealed concerns that the form was asking physicians to definitively rule in or rule out a diagnosis of sepsis. All diagnoses, including sepsis, are made on a balance of varying probability. It was felt that the sepsis alert form did not reflect this fact. Furthermore, there was a fear in getting a diagnosis wrong, which could have detrimental effects to patient care. For these reasons, doctors were choosing to ignore the sepsis alert form rather than completing it. The meetings thus highlighted the need for the sepsis alert form to be changed in order to reflect the clinical uncertainties that are presented to the physicians. Therefore, the options on the alert were changed from no and known sepsis to I don't think this patient has sepsis and this patient has treated sepsis. The two other options that were included were this patient is not under my care and I require more information or review.
Results for this project. Since the changes were made, the percentage of completed sepsis alert forms increased significantly from an average of 65% to 94%. The increased number of the forms completed led to an increase in the percentage of patients with a diagnosis of sepsis from an average of 28% to 45%. Furthermore, the percentage of patients who were coded as not sepsis significantly reduced from an average of 36 to 16%.
Increased engagement in the sepsis alert form has meant our sepsis data has become more reliable, allowing us to better identify specific areas or departments where sepsis care may need improvement. The new options allow the physician to confirm or refute the diagnosis of sepsis while simultaneously acknowledging a degree of uncertainty in this. Therefore, physicians were more likely to engage with the sepsis alert form. Although this may be perceived as a small or subtle change, it had a substantial effect on the psychology of the physician and thus their behaviour. Physicians were therefore much more comfortable with completing the form. This was reflected in our results. The increase in response rates to the new sepsis alert form reduced the phenomenon of alert fatigue because the alert would have been silenced once completed. This reduced the frequency of alerts and thus reducing the likelihood of alerts being ignored, warning of impending harm. The Big Room enabled us to better identify problems with the digital sepsis alert system, which would not have been otherwise been evident without the discussions between the different healthcare professionals during these meetings. The main lesson learned here was the importance of including the target end user, i.e. healthcare professionals, when designing digital systems intended to improve patient care and safety.